All right,
That's okay?
I'm
All right.
recording.
Okay. Good afternoon. Thank you so much for joining us. I've got a very, very brief intro, and then I'm going to turn it over to our presenters this evening. I am Debbie Jackson, for those of you who I have not met yet, and I'm your navigator producer for this afternoon. So if you have any technical questions or issues, please call me. I just sent you an email not too long ago with my phone number and email address. So call or email or drop me a note in the chat so that I can address your issues. Um, we will have an opportunity for you to ask questions of the presenters between presentations. And if you'll drop your questions in the chat box, then we'll be happy to address those at that time. I will be sending you a link to an evaluation survey at the end. I will also be checking roll at the end so that I can verify who's here. So our presentation today is about 30 minutes with Dr. Martin, about 10 minutes of questions, about 10 minutes with Ms. Duckett, and about 10 minutes of general questions to either speaker. Okay. All right. So just a quick intro. And I sent you this in the invitation, so I'm just going to read very quickly. Caitlin Martin is the assistant professor in obstetrics and gynecology at Virginia Commonwealth University in Richmond, Virginia. She received her BS at North Carolina Chapel Hill, and then her master's in public health and medical degrees from Johns Hopkins. She went on to complete her residency training in obstetrics and gynecology at the University of North Carolina Chapel Hill with additional training in addiction medicine. She practices as a general obstetrician, gynecologist, as well as an addiction medicine provider, caring for women with substance use disorder through the lifespan, including during pregnancy. As a physician scientist, her primary research interests lie in the intersection between addiction, gender, reproductive, and sexual health. Very interesting. Samantha Duckett is Associate General Counsel for Virginia Commonwealth University Health System Authority in Richmond, Virginia. She received her BA from Bucknell University and her JD from the College of William and Mary. Her clients include VCU Medical Center, MCV Physicians, Community Memorial Hospital, and Children's Hospital of Richmond. Her practice includes general health care, law, compliance, regulatory and risk management, physician services, and telemedicine. She has focused on substance abuse regulation since 2016. She is a member of the Virginia State Bar, the Richmond Bar Association, and the American Health Lawyers Association. And with that, I will turn it over to our presenters.
Hello, everyone. It's so nice to meet everyone. Thank you so much for that introduction, Debbie. I'm going to go ahead and share my screen. Please let me know if you don't see anything. Okay. Okay, perfect. So it's nice to meet everyone. I think I've met some of you either through collaboration for care for my patients here at VCU or maybe in some other type of domain. So today I'm going to be giving you a pretty brief outline of kind of an addiction medicine from my perspective as a provider, especially one that cares for women during the peripartum period. I speak kind of fast, so and I have a lot of material that I would like to get through, just given this lovely opportunity for all of us to get together in this COVID era. This presentation is being recorded and all my slides are available as a handout. I put a link to the chat if you would like to look at it at this moment, but I know that it'll get out to everyone afterwards. So I'm gonna go, I speak fast, but we're gonna have time for Q&A at the end. So these are some of the main points that I'm going to try to get through today with this presentation. First is we're going to go over the basic biology, nothing super crazy, about addiction, understanding it as a brain disease. We're going to talk a little bit about medications and different treatment options for substance use disorders from my perspective as a physician. And we're also going to talk a little bit about how treatment and medications only work if people have access to them. We all know about the barriers that people have, unfortunately, getting treatment when they desire it. And also the stigma and discrimination that exists for people with substance use disorders. We're really going to focus on our understanding about addiction as a brain disease and also as a chronic disease. Chronic diseases in my room as a provider are things like diabetes and hypertension. And then in understanding addiction as a chronic disease, we're going to go over how that means that people are not perfect all the time. And so there's ups and downs, just like there are for diabetes and hypertension. And it means that people aren't perfect 24 hours a day, every day of the year. And talk a little bit about recovery and what that means, especially for my lovely ladies that I take care of who are parenting. So first main point we're going to talk about today is that substance use and the opioid crisis are increasingly harming women disproportionately more than they are for men. I am a researcher, as Debbie mentioned, and so there are a lot of researchy slides in this presentation. Just because I speak data, that's how I understand things. So this was a paper that came out last year that was quite interesting in a pretty high impact journal, looking at the life expectancy in the United States and how the life expectancy in the United States in the most recent years has actually gone down, which is quite unfortunate. We've had so many years of our life expectancy going up because of all these lovely advancements that we have had in medicine and social structure, etc. But unfortunately, the last few years, mainly due to the opioid crisis, we've seen that life expectancy has gone down. And as you can see here, this is just one of the graphs from this paper looking at drug overdose deaths, something that we all know about, as unfortunately have been rising very much so in the recent years, especially among younger people, so people within those reproductive age. If you read the text in this paper, though, they looked at this data of life expectancy and also increasing death and mortality reasons for that, and they looked at it by sex. They looked at it between males and females. And unfortunately, they found that all of these terrible statistics that this paper found were happening more often and at a faster rate for women than they were for men. So they saw that this was especially happening when we looked at drug overdoses, suicide, deaths due to liver disease from alcohol use disorder, etc. So unfortunately, even though at one moment in time, men are more likely to die, there's more deaths due to overdose for men than there are for women, and there's more men who have a substance use disorder than women who have a substance use disorder. If we look over time, we've noticed that the increase in the badness associated with substance use disorders has risen more rapidly for women than it has for men, which is an unfortunate finding that we're seeing in epidemiology. And because I'm an OBGYN, and because addiction is a chronic disease, it extends into pregnancy. And so we also know that opioids are not the only thing. So we all know that there's other substances that also people use, not just opioids. And this includes during pregnancy and the postpartum period. And unfortunately, these sad statistics of the increasing badness associated with substance use for women that's been happening more rapidly over the last few years is the same during pregnancy also. And so the next point we're going to talk about is this kind of taking one step back and talking about substance use and substance use disorders. So not everyone who uses drugs or alcohol develops a substance use disorder. We know that current drug use is very common, and so people start using drugs or start using alcohol, and that is a common occurrence. This is looking at national data. I might reference this a few times during my presentation. It's called the National Survey of Drug Use and Health. It's the annual survey that SAMHSA, or the Substance Abuse and Mental Health Services Administration on the federal level, puts out every year. It's the big survey that tells us X number of people have depression, Y number of people get treatment for depression, you know, those big numbers that we want and that we look at in the literature and also in the news. And this is data from the 2017, but it's generally the same throughout the last few years, looking at the number of people who start using, so the first time they started using one of these substances. And you can see here it's quite common for people across 12 years and older they looked at to start using marijuana, opioids, cocaine, and of course alcohol and cigarettes. But not everyone who starts using or uses a drug or alcohol actually develops a substance use disorder. We know this. I'll bet some of us have wine or beer from time to time, but we don't have an alcohol use disorder. That's an example. So if you look at the same data, this National Survey of Drug Use and Health, this column right here is the number of people who use these substances over here on the left, any illicit drugs, opioids, alcohol, etc. This column here is the number of people who met criteria, so DSM-5 criteria, which is how we diagnose someone with a substance use disorder or an addiction. This is the number of people who actually had an addiction to that substance. And you can obviously see the stark difference between the numbers. So 15% of people had used some type of illicit drug, you know, within the last 12 months of the survey, but only 2% of people met criteria for a substance use disorder. And the same goes for alcohol, of course. 62% of people had used alcohol, but only 4% of people met criteria for an addiction to alcohol. And the same thing for opioids and other drugs, even excluding cannabis or marijuana. what makes the difference between those two columns that I looked at? What makes the difference between someone who, looking at the statistics, someone who has used a drug or alcohol, and then someone who unfortunately has developed an addiction to that substance? So I am not a psychiatrist, I'm not a neurologist, I'm an OBGYN. So don't worry, the biology we're gonna go through is quite, it's from up here. So I like to think of addiction with three main bubbles, and this doesn't happen. These three main bubbles in the example I'm going to give does not really apply to every patient I see, but it's a good way of understanding how it applies for a lot of patients, especially when we're considering patients with opioid use disorder. So the first bubble that kind of leads to the substance use disorder diagnosis or addiction is physiologic dependence. So I'll give an example. I broke my knee, I had to have surgery. My doctor prescribed me oxycodone 10 milligrams 3 times a day. I was on that medication for a while. Maybe I had some complications from my surgery, etc. I ended up having to be on that medication for some months, for example, unfortunately. When my knee got better, I started to taper down off of that oxycodone and try to get off that medication because I no longer needed it. And in doing so, I had withdrawal symptoms. I started feeling hot and cold, sweats. Lots of us have unfortunately seen patients in opioid withdrawal. And I started having cravings too, potentially, for that substance. That was because my body had grown physiologically dependent on that substance. I don't know about you, but I am physiologically dependent on caffeine. So I have to drink coffee every day, or my husband will tell me, where's your coffee? So I have developed a dependence to caffeine, I can say that. The next aspect that leads someone, unfortunately, to the diagnosis of addiction or substance use disorder is misuse. So we'll go back to my example. I broke my knee, oxycodone 3 times a day, 10 milligrams. And then over time, let's say I unfortunately started snorting that medication. I started selling that medication. I started taking more than my doctor prescribed. I started stealing medication from family members, etc. Those are all examples of misuse of at least a prescription medication. And so that is one more bubble that doesn't apply to everyone, but especially patients who have an addiction, who develop an addiction to prescribed substances. That is a common thing that we see too, misuse of that substance. Now, in order to have the diagnosis of substance use disorder, you have to have this bubble now. This is the maladaptive behavior bubble. Going back to my example, broke my knee, 10 milligrams 3 times a day. I tried to come off of it. I had lots of cravings and withdrawal. Then I realized I couldn't get off of it. I started misusing it, snorting it to try to make sure that I felt normal because I felt so sick when I tried to come off the medication. And then, unfortunately, that led to me potentially losing my job, getting a divorce, maybe not spending time with my children as I wanted to, maybe having legal problems, etc. But despite all those terrible things that were happening in my life, and I recognized it was from the misuse of this substance, I continued using it. That is continued use despite adverse consequences. Once you unfortunately meet that criteria, then you have developed the disease of addiction and you can be diagnosed with a substance use disorder. So what we're going to go into too is, why does that happen to some people but not other people, right? I've had patients who maybe misused some substances but never developed the disease of addiction. I've had people kind of all across the spectrum. We've all seen people like that. But we're going to go over a little bit of the neurobiology behind it to understand that addiction is a chronic disease of the brain. It's not a moral failure or simply a choice. Unfortunately, there are lots of factors that lead to patients developing that last bubble and really having those terrible things happen in their lives. So this is, understanding, we're going to go over a little bit about the brain. And so the big take-home points from the brain biology part is that addiction is a brain-centered condition whose symptoms are behaviors. This is why, as a doctor, treating addiction is quite challenging. So if I have a patient that I'm following for hypertension or high blood pressure, that's another chronic disease that's very common in the United States. I follow a patient over time. What I do when I see that patient is I take a blood pressure. I have a number, right? I have something I can look at and I can track them over time. That's very good and makes my job a lot easier because I can track this number of this blood pressure over time. Addiction is a little bit more challenging to treat as a chronic disease because the symptoms of it are behaviors. It's not a number, it's not a blood pressure, it's not a hemoglobin A1C or what you do for diabetes, for example. It's behaviors. Behaviors sometimes don't check all the little boxes, and it's not a pretty number like a blood pressure or a hemoglobin A1C or a sugar log is for diabetes. And as I went through before, in order to meet the diagnosis of an addiction, it means that you've continued to use the substance despite adverse consequences of using that substance. This is the definition of addiction that was actually just updated this past year, I believe, by the American Society for Addiction Medicine. And so it says addiction is a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. People with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. Prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases. I like how they end with a positive aspect to their new definition, by the way. So what are all these changes in the brain that lead someone to lead down that path that we talked about and have all those bubbles that led to the diagnosis of substance use disorder and continue using despite adverse consequences? Well, in brief, what happens is that when you use a substance, cocaine is a good example. That's what this diagram here is showing. What happens when you use a substance is that you get super high levels of these things called neurotransmitters or chemicals in your brain that go up. The common ones to know about are dopamine and serotonin. Dopamine's the big one. Dopamine is that neurotransmitter where, I don't know about you, but if I go walk my dog or I eat a piece of chocolate, I watch a really lovely movie, I feel all warm and fuzzy on the inside. That's dopamine in your brain. It's that feel-good type of neurotransmitter that we have in our brain that goes up and down. Versus if you're feeling depressed, people with the disease of depression, for example, they usually have malfunctions in their dopamine receptors and the way that their dopamine works in their brain. Now, if you use a substance over and over again, your brain has super high levels of dopamine over and over and over again, to the point where those levels of dopamine are too high. Your brain is not meant to have levels of dopamine that high. The levels of dopamine that our brain is equipped to handle are those levels like spending time with your children, with your family, eating the chocolate that I like. It's not meant to have those super high levels that you get when you use cocaine or other substances like that. And then what happens over time is that when you have these super high levels over and over and over again, that leads to damage to your brain. So that leads to many different things that happen in your brain that lead to your brain not recognizing the dopamine anymore. So the way that the neurotransmitters are, that your brain recognizes them, called receptors, become dysfunctional. They don't work. These circuits in your brain that talk between all the different parts of the brain, the wires start getting crossed and they don't work as well. So what happens is that person becomes slowly over time unable to no longer feel that high sensation anymore that they used to, because their brain has changed. Their brain physically cannot feel that level of dopamine that they used to feel. And so what happens is that their brain becomes what we call in the addiction in the neurobiology world, hijacked by dopamine. So what happens is that your brain just says, I need to have those levels of dopamine. And it just keeps on looking and looking and looking for those levels of dopamine and that feeling from those levels of dopamine that it had so many times from repeated substance use. But it can't feel it because the brain has now become distorted and no longer works. And so what happens over time is that your brain just literally says, I need that dopamine. I need that dopamine. And that's what leads people to do the things that they need to do to get that drug, to get that substance. Even though they don't want to do these terrible things, their brain becomes hijacked by needing those levels of dopamine, but they physically are unable to feel it anymore. And we know that this type of the dopamine hijacked hypothesis for the disease of addiction has been known for quite some time. As you can see, this is an old slide from the NIH, the National Institutes of Health, where there's been lots of research that's done these fancy fMRI studies where you look at people's brains between people who have the disease of addiction and the people that don't. And they've seen these changes that happen in people's brains over time because of those repeated substance use exposures. And so unfortunately what happens, because someone's brain becomes physically unfit, it's unwell, how I explain it to my patients is that they can't feel that dopamine anymore. Their wires are crossed. I say the chemicals are imbalanced. That's how I explain it to my patients. What happens over time, after those repeated exposures, the brain changes in the dopamine receptors, also in the structure of the brain, is that people no longer can feel even high anymore. And it's quite sad because sometimes my patients who are entering recovery and maybe are getting better, they'll get depressed because they're no longer using that substance and they're trying to get better, but they're unable to feel happiness. And so we've all probably seen maybe women who had babies, maybe they're doing well from a recovery and addiction standpoint, but they look sad, right? You're like, why are you so sad? You love your baby. They say they're doing well, but they're having depression. It's because their brain is not healed yet. Their brain is still quite sick. And it's because they can't feel that high anymore. They can't feel that euphoria, even for the things that should help them feel high and feel warm and fuzzy on the inside, like their children or my chocolate, for example. And so why do some people develop this terrible disease of the brain and why not other people who use substances? Well, a lot of people are trying to figure that out and are dedicating their life's work to that type of research. And so it's quite complex, is my understanding from all my reading in this area. It is an interaction like many other complex diseases that we know about these days between a lot of it is genetics, unfortunately. A lot of it is an environment, unfortunately. Then there's the exposure to the drug, and there's some type of interaction between these things and the drug. And if someone was already set up for failure, they had maybe adverse life, they had trauma in their childhood, they had trauma in their past life, and then they have these genes that put them at risk of addiction, and then they're exposed to substances, they're already at risk, and that leads to the disease. Versus someone who was not set up for failure, as I like to say it. They might use a drug and then not go on to develop addiction and be able to stop using that drug before it gets to the continued use despite adverse consequences. Now, I take care of women, and so something very important to know is that women are part of, or is the sex compared to men that is set up for failure for this. Women have a lot of the comorbidities, a lot of those things that set them up to be more likely to develop the disease of addiction. The biggest one is adverse childhood experiences. I know I'm speaking to the crowd here, that's why this slide is here. Women are more likely to have more ACEs, if you've heard of ACEs or adverse childhood life experiences. Women are more likely to have more ACEs than men, okay? And when we look at the number of ACEs that a person has, there is what's called a dose-response relationship. So if I looked at a graph here of the number of ACEs and your risk of developing the disease of addiction, it literally is a straight line. So the more ACEs you have, the more at risk you are of developing addiction. Put that together with women, and they're already unfortunately set up to be more at risk for developing addiction than men in some circumstances, especially when they unfortunately have a trauma history. So because we're not going to focus on pregnancy today, but I'm happy to take questions at the end. But one point to get across about pregnancy is that addiction's a chronic disease. Chronic diseases, when someone gets pregnant, doesn't go away. I would love if people's hypertension and diabetes just went away when they got pregnant. I don't know if I would have a job, but it would make my life a lot easier. Unfortunately, addiction is just like those other chronic diseases. They continue into pregnancy just like any other. And what's important to know is that evidence-based treatment for substance use disorder is effective, and we're going to talk a little bit more about that and how we should be tailoring that to an individual's needs. So the gold standard for how to treat substance use, I'm getting into positive things now about treatment, is it's multifactorial. It's having, this is an old slide here from NIDA, but you see there's multiple things that people should be offered to treat a substance use disorder. This doesn't mean that everyone needs everything, but just like earlier when you saw that slide of all those different risk factors for addiction, we need to also fix and make sure our treatment modalities look just like that. We're tailoring, we have things available for whatever that risk factor is that led someone to develop the disease of addiction. We should have a treatment modality for that also. There are medications for opioid use disorder. We're not going to go into super detail about them, and I'm happy to answer questions, but a big thing to know is if you're going to have 1 type of addiction to a substance, opioids is the better one to have because we have good medications. I don't have a Suboxone, I don't have a methadone for cocaine use disorder. That just does not exist. But I do have great medications for opioid use disorder that actually do work. And the reason that they work is that they're based in brain science. They're based in all that crazy neurobiology that I went over with you earlier. They're based in all that, so they work well. And in brief, what they do is that they work at the mu opioid receptor that's present in our brain and rest of our body. And how they do that is they attach to that receptor, the same receptor that heroin attaches to, or oxycodone or Percocet. But what's nifty about them is that they're not short acting. So heroin, Percocet, all those, they're very short acting opioids. That's why people can use them and they can feel high. They can abuse them. They can crush them and they can inject them. You know, you can abuse those short acting opioids. Methadone and Suboxone, or buprenorphine, which is the active ingredient in it, are both long-acting opioids at the same receptor. And so they're much harder to abuse. Of course, people can abuse anything. I'm an addiction doctor. I see it every day. But it's pretty hard to abuse these medications when you're taking them as prescribed, methadone and buprenorphine. So I just said this point about how they're based in the brain science. I got a little ahead of myself. The big thing that I deal with a lot is that people think that buprenorphine and methadone and things like that, they are just substituting one drug for another. They're not. They're based in brain science and how to stabilize all that crazy wiring, all those crazy chemicals. They stabilize all that in someone's brain. And when someone takes it as prescribed, they're not getting the big highs and the lows anymore. They're not abusing that medication. They're actually just stabilizing their brain so they can work on their recovery. So how I like to explain it to my patients and to anyone else is that medications for opioid use disorder, they're really good. I wish I had them for every substance because they stabilize the brain from a physiologic dependence. You shouldn't have any cravings or withdrawals when you're on these medications as prescribed. Therefore, people should and typically stop misusing medications or drugs. And then they typically also, if they're taking their medications as prescribed, it will help keep them from doing all these maladaptive behaviors or continued use despite adverse consequences. And for not everyone needs medication, that's just the way it is. But for the patients who it does help them, how I like to explain it to them, because it's stabilizing your brain, it helps them have a platform for recovery. It's really hard to go to group, right? Mom's recovery group like we have at Motivate, and participate in group, or go to counseling, or go to your child's PTA meeting, whatever that is, if you're just thinking about heroin all the time. I don't know about you, but if I'm in a lecture and I'm really hungry, I'm not listening to that person who's talking because I'm so engaged in what's going on in my mind. All I can think about is I'm so hungry. I can only imagine what my patients go through with the cravings that are coming from their brain for drugs. And so it's really hard to go out and do all those other things for their recovery if they're focused on the withdrawals and the cravings. And these medications work really well to help people get there. So in summary, what is addiction? Well, this is how someone starts out. They feel normal, they use a drug, they feel really high. They go up, down, up, down, up, down. Over time, because their brain becomes dysfunctional, no longer works, you can see how it goes down. They get to the point over here where they no longer can feel that euphoria because their brain just stopped working. Their dopamine just isn't working. But they continue to use it because their brain is hijacked by needing more and more dopamine all the time. That's all of your brain is doing. It's taken over their body. So over time, it leads to them just using the substance to feel normal. They're no longer, unfortunately, over here because that leads to them not feeling this later on, but they're using that drug to feel normal in the middle and avoid feeling really sick down here. What's great about medications for opioid use disorder is that they keep people here. They keep them right in the middle. And so when people are taking the right dose or taking it as prescribed, they feel normal right here in the middle. They don't have to do all these super highs and lows anymore. They don't feel that physiologic need to go use. Yes, of course, there's life circumstances that lead to them using because the brain is not yet healed. So if they get really stressed out, they miss a dose of their medicine, etc., the craving could potentially come back. But if they're But for the most part, when someone's on a medicine that works, it keeps them here and it keeps them feeling normal. Then go work on the things they want to do for their recovery. Again, side note about pregnancy is that these medications are recommended in pregnancy and especially in the postpartum period. Again, not everyone seems to be on a medication for opioid use disorder who has an opioid addiction, but for the patients who it works well, it works really well, and we definitely need to make sure that we're promoting patients who want to be on medications to continue on those medications during pregnancy and postpartum. And these are national recommendations from SAMHSA. And why do we do this? Well, what's really good, a positive thing, is that there's lots and lots of research that shows that women who receive during pregnancy comprehensive addiction treatment, they have child outcomes that look similar to women without the disease of addiction. And that has been shown over and over again in robust research studies. This is just one example from 1978, Loretta Finnegan. You might recognize the name, who made the Finnegan score for NAS. And so we've had multiple studies like this since then that shows that if people have the disease of addiction, they're getting care, their outcomes, this is just one example here of low birth weight, looks similar to people without the disease of addiction. And so treatment works. What we just need to do is help women get into treatment and be compassionate and do everything we can from a support standpoint to keep them in when it's working for them. And the other thing to know is that when women are in treatment during pregnancy and postpartum, you are saving women's lives and you're keeping families together. This is recent data from Massachusetts that looked at overdose events during pregnancy and the postpartum period. Big take-home points, you can see that overdose events go up very much so through 1 year postpartum compared to during pregnancy. And you can see here this orange bar and this gray bar. The orange bar is for the women who were on medication like methadone or buprenorphine or Suboxone. And these are the number of events for women who are not on medication. And you can see here that there's obviously a clear difference between people who are getting treatment with the medication and people who are not. So doing what we can to help women stay on their medication, stay in treatment, whatever that treatment is for them, that's working for them during pregnancy or right afterwards, whenever, is such a good thing. And we are saving women's lives and keeping families together. A couple more things I'm just going to mention is that, unfortunately, because addiction is a chronic disease, even with treatment, there are going to be periods of remission and recurrence that when it does happen, we need to address it with increased support. Just like diabetes and hypertension, I don't know if anyone has diabetes, but maybe you've gone to your doctor a couple times and you bring in your sugar log and maybe it's not as good as it was last time. You had some highs. You missed some doses of your hypertension medicine. You go to the doctor and your blood pressure is really high, right? And then it gets better. Just like those chronic diseases, addiction is the same way. There are going to be ups and downs as someone's brain is in the process of healing. And so, like I like to say, is that relapse is a recurrence of a chronic disease. So I don't use the word relapse in my clinic. I use it with patients when I'm trying to speak with them because it's their language that they use. But what I teach all my medical students and trainees is that it's a recurrence of a chronic disease. So someone will have a substance use recurrence. I'm not downplaying it. It's definitely something, that's my job, literally, is to help women when they get to that point and do what we can to increase treatment, tailor the treatment, do what we can to give them more support services. And I know I collaborate with a lot of lovely people on this call too, have helped a lot of my patients, which I'm very grateful for. But it's good to remember that it's a chronic disease of the brain. There's going to be ups and downs, just like diabetes and hypertension. And I've gone over it before, but this extends into pregnancy too. Women don't magically become a whole different person just because they're pregnant or postpartum. Their brain's the same, their brain's in the process of healing. I'm going to skip through a couple slides because of time, but this is a positive thing, is that we know that over time when people reach recovery, so recovery is not just abstinence or reduced substance use. We all know it's wellness, right? It's being able to be with your children, be with your family, get a job. I know everyone on this call knows about that. And so what we've noticed though, on a positive note, is that when people reach recovery, their brains can heal, which is so good. I can't always tell someone as a doctor, I can help you get healed from whatever disease they have. But for addiction, I can tell them that your brain can heal. all those terrible mismatchy things I went over earlier, they can get better. And they can get better when you're on medications like Suboxone and Methadone. They can get better when you're in a recovery group, NA, whatever's working for that person, their brains can heal. And we've seen that in research over and over again. A couple of things I'll say about urine drug tests, because I just noticed that there's some misperceptions about that everywhere I go. Urine drug tests should never be used as a comprehensive assessment of someone's recovery or treatment status. It's a one-time test. There are lots of pros and cons to urine drug tests. A point-of-care urine drug test, so the one you do and you get back pretty quickly, it's very common to have false positives on that urine drug test. So it's important to remember that if you get a urine drug test for something and there is a positive result, no action should be taken on that test, especially if it's inconsistent with the person's report of what they used, unless you get confirmatory testing, which is done with mass spectroscopy. We all know about patient consent, and Samantha's going to go over that more, but patient consent should be done for any specimen before it's collected. I tell all my residents to do this, and they do this here at VCU. And like I mentioned earlier, as you probably have already know, I know saying things that you already know, talking to someone, asking them about their substance use, assessing how their life is going in their recovery is always the better thing to do. And getting a drug test when it's necessary, for me, it's necessary. It's what I use. It's my blood pressure, right? It's one more data piece I have in addiction treatment. But when you are assessing a patient how they're doing in their recovery, a one-time test for a chronic disease is not going to tell you the story that you need. It might tell you some data for right then, if it's done appropriately. It's not going to be a comprehensive assessment of how that person's chronic disease is doing. It's just like if you have diabetes and you come in with your glucose log and you might have eaten a donut yesterday and your sugar went up to 250, but you were eating really well those other days, but your doctor just said, well, you know what, you've got to go up on your insulin. You're not doing well because you had 250 yesterday from the donut. It's a similar concept. And so we need to make sure that we recognize that it's one data point that should be considered within a conversation of multiple other assessments for people with the disease of addiction. Everyone knows that people need treatment in the United States and are not getting it. I'm not going to go into this at length, because everyone knows that unfortunately there's a huge treatment gap in the United States. Less than 1 in 10 people with a substance use disorder, according to the most recent data I have, are getting treatment for that substance use disorder. It's terrible. When you look at other chronic diseases like these here, you can see a major difference between the two. And unfortunately, those numbers don't get much better for women. This is a recent study that Dr. Turplin and I completed, where we looked at the most recent NISDA data, that national survey data, and we found that unfortunately, less than one in 10 reproductive age women, okay, so 18 to 45, I believe we did, less than 1 in 10 with a substance use disorder was receiving treatment. You would think it would get better in pregnancy. Oh, we got a little bit better. It was almost 13%. 13% of pregnant women in the United States were getting some type of treatment. This does not involve necessarily people getting comprehensive treatment with medications. When we statistically look to see if pregnancy increased your odds of getting treatment, like if it made it more likely, it wasn't even statistically significant because the numbers are so low. So what we need to remember, this is the last thing I'm going to say, is that there's a lot of reasons why people don't get treatment. I do not have time to go into all that today, and I know everyone on the call knows about all the barriers that the people we work with and my patients and such deal with. It's a lot. One of those barriers is stigma, discrimination, and prejudice against people with the disease of addiction and against addiction treatment itself. When we looked at the same NISDA data, Dr. Turplin and I recently, we looked at all men and all women, and we looked at the reasons why people who wanted treatment said, I wanted treatment, but I did not get treatment. What were the barriers that they encountered? And you can see here that the most prevalent barriers had to do with how people perceived their treatment. They didn't perceive that they thought their job would discriminate against them if they were in treatment. They didn't think the treatment would work. They thought that treatment was a terrible thing, etc. Those are the big things that are keeping people from entering treatment. Given that, and then the low number of people who actually receive treatment, the two things we need to remember is that when people need treatment, we need to continue doing all the great work we're doing. And this is more of a motivating statement to help people get into treatment. And you guys all know how to refer people to me if they need it. Secondly, when someone is in treatment, we need to do everything we can to support them. We need to do everything we can to say you're doing the right thing, because only less than 1 in 10 women in the United States who need treatment during their reproductive ages is actually getting it. So the people who are in treatment, we need to keep them in treatment, because that is, and we need to support them and encourage them in that, because they're one in a very small minority. So I'm going to end with some quotes from my patients from a recent qualitative study that we completed about stigma and discrimination that my patients have endured. There's lots of positive quotes, but I didn't have time for all those. But I just want to open up that there are so many opportunities. We work with people day in and day out, and I feel so privileged in my job that I can help people in some of their hardest states and some of their best states, and I can help them get to that point. And so what we need to do is continue talking to our colleagues, continue talking to our family members, continue talking to our church groups, etc., and educate them about addiction, how it has a neurobiological basis. It's a chronic disease. Treatment works, and we need to make sure that we're talking treatment up. It is not a failure to go to treatment. You're not doing the wrong thing. You're not substituting one drug for another. And we in this room, we have such great opportunities to help educate others. And we all know that it's one conversation at a time. You having that one conversation with your friend about the disease of addiction and medication and etc. might lead to that person, if they were going to maybe say something harmful or not use person first language with someone with the disease of addiction, that might be one less stigmatizing interaction that person may have in the future. And so we can definitely change things and help women and help people get into treatment and feel comfortable and not feel judged for accessing it. And I'll end there.
Okay, we don't have any questions in the chat box that I can see. If somebody does have a question or wants to make a comment, if you could go down to your reactions at the bottom of your screen and maybe do the thumbs up, just so we can recognize you. Okay, looks like Janet Palmer is raising her hand. Well, actually, she's clapping, but thank you. Janet, you want to unmute yourself and ask your question or make your comment? Are you able to unmute yourself? Okay, I thought I saw another hand too while we're waiting for that. Okay, I got a question from Tiffany Lee. What is the average length of treatment?
That's a good question. There is none. So what I would recommend is that when someone on a medication, for example, I get that question a lot. The data is completely clear that if someone is getting benefit from a medication like Suboxone or Methadone, the longer they stay on that medication, the better the outcomes are long term. I have this discussion all the time with my patients. The downside is that there's so much stigma about these medications that even if someone ends up starting it during pregnancy, for example, they feel like they need to get off of it immediately because they're feeling pressure from their family members, et cetera, who are telling them it's not the right thing to do. But the data is very clear that the longer you stay on your medication, if you're on medication, for example, to help you to reach your recovery goals, the better your outcome's going to be. And sometimes that's years.
Hey Debbie, it's Alexandra. I have a question real quick.
Okay, go ahead.
I guess it's a question / observation. So I've found that the courts, at least a lot of the judges I've been in front of, have been pretty understanding of recovery being a road and not like a short trip that suddenly ends and everyone's better. And I think that we do a good job of being supportive during active recovery and folks who are, doing the steps and really trying. I think what we have an issue is that we also have many cases where we're not dealing with individuals who are even willing to admit that they might have a problem, or they're not even interested in starting, or we try to help support starting and they don't. And kind of like you said, with the long time frame, like that puts us in a position where it's like, well, we have a 6-month-old who we just can't hang around for 3 years and come back every few months in the hopes that your home situation is slightly better because the parent finally has gotten to a point of wanting to recovery. I guess, what can we do to help people get on board or ready to be in that recovery when we're dealing with the situations that aren't already there?
Gosh, if I knew the answer to that question, I feel like I would.
Yeah.
It's very hard, right? And one thing I would say about that is that is the disease of addiction is terrible. I mean, it's leading to people continuing to use and dying. I had a patient die recently who was in that situation. She just didn't, wasn't there, was not ready to accept help. And what I have noticed is that some people are just not going to be there, and it is a road. And if you've had a family member, you might know this a little more personally, for example, where people just are not ready for help yet, despite you physically being there and handing things to them on a silver platter. And that is that neurobiological hijacking that's going on, and it's why it's a terrible, terrible disease. What I do, and I don't know if I don't know the magic bullet is, I'm just there. I just remind them I'm here for you whenever you're ready. And your situation is more complicated than mine. In that situation, you have multiple people to worry about. But what I do as a provider in my situation, I just remind them that I'm here whenever they're ready. And what I do too is I educate all that stuff I just told you guys about the brain and how the medications work. I say those things to my patients. I explain the brain stuff. Mm-hmm. I explain everything I said to you guys today. I say the same things to my patients. And sometimes it's just that conversation of explaining to them what's going on inside their brain. Why are they feeling sick? Maybe they might not necessarily act on that at that moment, but it sinks in sometimes, especially when I can involve maybe their partner, their mom, their sister, whoever may be that good support person in their lives, and I have that brain conversation and treatment conversation. I do feel like one conversation at a time of education can go a long way, not just in the levels that I talked about, all the opportunities we have in our jobs to help educate and be compassionate and destigmatize the disease, but also within our person-to-person interactions with our clients and my patients.
Do folks need a referral to go over to your clinic, or can a person walk into the Motivate clinic and be like, I'm willing to talk to someone, I want to maybe start treatment?
Yes and no. You need a referral technically to get into Motivate Clinic, which is the outpatient clinic. You have to have a referral from a VCU provider. I run the OB Motivate program, which is a collaboration between Motivate and OBGYN, where women in particular, I can get them into another clinic too. So as self-referrals. So they're yes and no.
Okay, thank you. That's helpful.
Thank you. And I'm sorry, Samantha, but I went over, so sorry about that.
There was a question.
I was going to say, we've got another question, but I was thinking that, well, we may want to go to Samantha's presentation and then circle back if we have time.
Sure. And so mine is much shorter and unfortunately not as exciting or interesting as Dr. Martin's, but thank you all for being here. At the end of the day, I'm going to try to share my screen with you. And thank you, Debbie, for setting this up and, giving us the opportunity to interact with DSS and everyone else on the line. And thank you, Dr. Martin, for your passion and your concern for some of our most vulnerable patients. I always learn so much from you. And the way you ended your presentation actually with the stigmas is a great segue into my portion of the presentation, because I'm going to be talking about the Part 2 regulations, and those are laws that seek to address the stigma that unfortunately exists for those who have substance use disorder. So let's get started. So certain substance use disorder records have special protections that are more restrictive than HIPAA. And I think most of you on the call know that by now. The reason for this is because 42 CFR Part 2 affords special privacy restrictions to substance use disorder records created by Part 2 programs. And VCU Medical Center's Motivate Clinic, as well as Dr. Martin's OBGYN substance use disorder program, are considered Part 2 programs, and these strict standards apply. It's important to note that Part 2 creates a blanket ban on disclosing records. The only way to disclose is if Part 2 specifically allows it. Otherwise, it completely prohibits us from releasing these records to anybody except the patient. And it's also important to understand that even though we say the word records, we really mean any and all substance use disorder information, including the fact that we're seeing a patient for substance use disorder treatment. It applies to verbal communications, and it also applies to requests for our clinicians to come testify in court about a patient or answer your questions about a patient. I also want to mention some of the changes to Part 2. You might be following the changes that seem to be coming out rapid fire. SAMHSA issued a new final rule last month, and there will be another final rule in March through the CARES Act. While these changes have affected some aspects of the clinical side of things for us, which we're still trying to figure out, the process for disclosing records hasn't really changed. So if you've been trying to follow along with that, with one little exception, which I'll get to later, there really haven't been many changes to the process for disclosing or requesting records. To authorize a disclosure, you still need patient consent, or absent that, essentially, you need a court order. And I'm going to try to quickly describe for you what is required for each of these avenues and why patient consent is the easier way. This slide here summarizes the main takeaway from my presentation. So if you can only tune in, I know it's the end of the day, for one slide, this is the slide to look at. To obtain records on a substance use disorder patient or testimony about a substance use disorder patient, we need the patient to explicitly consent to this, or we need a court order and a subpoena. And I'll explain on the next slide why we need both. Our clinics are not equipped to handle the amount of records requests that we receive. All requests should go through our HIM department, our Health Information Management department. This is for consistency across our large enterprise, and also it's to ensure that our clinicians have time to treat and manage and take care of their patients instead of responding to these record requests and consulting with legal to make sure that they can release the records and that kind of thing. And I have the information here on this slide, which I can make available to you as well after. So let's talk about patient consent. This is the best way to obtain the records, and the best way to get the patient consent is to use our form that we have. This is because the Part 2 regs have very specific requirements for consent, and our form includes all of the required elements. We'll accept other forms if you have them, but know that HIM is going to have to send that to legal to review and approve the release of it, and that just takes more time. I gave Debbie a PDF of our release form, so she can distribute that after if you don't have it already, and you can just have your clients fill that out and send it to us whenever you need to have records and the patient's willing to consent. Also, I wanted to point out that little bitty change with the new final rule that came out last month. They did make it slightly easier for you to get records in that previously the patient had to identify a person to give the records to if the person is not part of their healthcare team, and now they can simply request an entity. So for example, you could now say DSS instead of Debbie at DSS. So that should make things a little bit easier. If the patient refuses consent, in order for us to release the records, we're going to need a subpoena and a court order. And this also goes for requesting testimony from our clinicians about a patient. We need a subpoena and a court order. Part 2 specifically lays out that the order is needed to authorize the disclosure, and the subpoena is needed to mandate it. So the thing to keep in mind here is that if you only have a subpoena, we're still prohibited from releasing the records to you because we don't have an order that authorizes us to do it. So we'd have to then go and challenge the subpoena. I want to just go through really quickly some of the requirements for getting a court order just to show you how strict this rule is and why patient consent is important here. a judge has to determine one of three things. I have them listed here. The judge has to find that there's a risk of death or severe bodily harm to third parties, like kids, for example, or a serious crime like homicide or rape is being investigated, or the patient herself is testifying or presenting evidence about her substance use treatment. And absent any of those things, the judge should not be ordering us to disclose these records. There's a process for obtaining an order in cases like yours, meaning non-criminal cases. I found that a lot of judges are not familiar with this at all. I have the code section 2.64 saved as a PDF, which I also provided to Debbie, so you can look at it if you're interested, or if you have a patient who's not consenting. There's requirements like notice to the patient, notice to the record keeper, which would be our HIM. You have to conduct a hearing and show good cause and all of that. And there's, of course, a parallel process for criminal cases, but in the interest of time and the subject matter here, I'm not going to go into that. But that's really all that I wanted to tell you all. If you have any questions, I'm happy to answer those. And I'm also, happy to provide any sort of forms or documents or additional information about this subject to ease the burden that maybe both sides feel when we're trying to share records about our patients.
We have 3 questions in the chat box, and I'm going to read them all, and then you can decide which ones you want to answer in the time that we have remaining. The first question is, what treatment support is there for cocaine addiction? The second question is, how do we know when the parent is well enough to have her child return to her? And then a third question is, how long it takes for the brain to totally heal? There also is a question about sharing the PowerPoint, so that I think that is probably to you, Samantha.
I can share the PowerPoint. Yeah, I'm happy to do that.
Yeah, we have Caitlin.
So I can speak to a couple things. The first thing is the cocaine question you said. Let me just share my screen again. So the big thing is this multidisciplinary and multidimensional framework for treatment. Sadly, we don't have I don't have a Suboxone for cocaine, sadly. But treatment works in the fact that we do need to make sure that we are tailoring all these little bubbles here that are in this diagram to whatever the patient's needs are. Commonly in real life terms, what that means is that if my patient has a comorbid bipolar disorder, ADHD, some other psychiatric diagnosis, I get her in with psychiatry. Let's say that she has a medical condition that's leading her to have pain, and maybe that means that she needs to see a medical provider for her pain disorder. In addition to behavioral health, like counseling, everyone needs that most of the time, and then also recovery support, like multiple recovery support groups. I would make sure that at least one of either the recovery support or the behavioral health component is a mental health trained specialist. You'll get more bang for your buck if that's a substance use trained specialist in addition to a mental health trained specialist. And peer recovery is a huge thing. I don't have to go into that. Everyone knows peer recovery is very good for all of these people with cocaine. The other question was about when do I know if a patient is ready to have her children back? I don't do that. That is not my job. But I can tell you, so I don't know how to answer that question. I think that is a substance use and addiction is one component of a patient, of a person. It's one disease that they have in addition to having other diseases like obesity, diabetes, hypertension from a medical standpoint. But it's also poverty. It's also unstable housing. It's also having an abusive partner in the home. That we rely on my social work colleagues. I know Carly's here, for example, our social worker from the clinic. Like all those bubbles in the treatment is multidisciplinary. So I don't remember how many people I have on my team, for example, here at VCU, but it's over 10 people on the team taking care of my patients. And so we tailor what patients need based on their needs. And so just like I do that from a treatment standpoint, I know that you all do that too from a social standpoint. And so I can't speak to when they're ready because that's not my job to determine that, but I can say from an addiction standpoint, It's important to remember that's just one name, that's just one piece of the puzzle. And then the other question was, how long does it take the brain to heal? It takes a while. Every patient's a little bit different, because remember, the big box that led to someone developing the disease of addiction was genetics. And we do not know enough about that big box of genetics. We know more about environment. We know about ACEs, for example. But all those genes that lead to someone being at risk of addiction, those genes are probably playing a role into how long it takes someone's brain to heal once they're in treatment and reaching their recovery goals. So how I physically figure that out is if someone has, doing well, I ask them, how are you doing? And so an example I get is that people always ask me, how long does someone need to stay on their Suboxone for after they deliver their baby? There's no right answer, because every patient is different. Just like we need to individualize treatment to everyone, there's no box, and there should be no protocols for everyone. Everyone is an individual. But most of my patients, I say, I recommend that you continue on your Suboxone through at least a year postpartum. And I say, I will take care of you no matter what, because some people don't need to be on it through at least when your baby's a year old. But I say, after taking care of a lot of women through this process, that is what I recommend. And I say, when your baby's a year old, you and I are going to sit down and we're going to talk about how your life is going. How's your recovery? How's your home life? How are your children's health, etc. And we're going to see, is that a time where you want to come off your medicine, or is it not a good time? And let's continue the course. Remember, there's no rush to get off medicine. The longer you're on it, the better you are long term. And I have a lot of patients. I've been here for 2 years now. I have a good cohort of patients that have been with me for a year. Their babies are getting much bigger. And let's just say it's very rare when someone decides on that first baby birthday that they want to come off their Suboxone, because they were saying, you know what, I'm doing so well, and I'm going to continue the course, and I'm going to see how things go next year. And that's completely fine, because you know what, that patient knows what's best for them and what's best for their family.
Okay, I don't see any more questions in the chat box. I do have a couple of comments. Thanking you all for the presentations and commenting on how informative this has been. So I don't know if anybody else has anything else they want to wrap this up with. I know it's 5:02 now. I know, Caitlin, you have to go.